Hello VetVelters and welcome back. It's been a wee while between episodes, but I have an excuse. I was learning and I was live podcasting. See, last week was the VEX Spring Symposium up in Port Douglas, and I was there as the VetVelt to do some live interviews and to stuff my brain full of some incredible quality critical care CE. I had the privilege of sitting down with some very smart people to dig for highlights and key takeaways and to get some questions answered about their talks. And did I ever have some questions? If you are a VEX member, so that's the Veterinary Emergency and Critical Care Society, or one of our clinical subscribers, you should check your inbox for an invite to the space where the video recordings of these sessions are currently residing. Or for our clinical subscribers, hold tight, we'll be releasing the audio as podcasts on the ECC stream over the coming weeks and months. Here's a little teaser. It was the general consensus amongst the doyens of critical care that we probably don't have to put animals that have ingested potential nephrotoxins on preventative IV fluids. Yes, we're talking about those damn grape and raisin ingestions who sit in your hospitals for 2 days on fluids, barking their heads off and driving everybody crazy. We'll let you know when that episode goes live, but I'm super excited. I also had the privilege to meet many of you, our VetVelters, in person. And can I just say that I am in awe of how cool you all are and inspired by your support and feedback. I really do feel privileged to be a part of such a dynamic and passionate group of people, and I'm pumped to keep using the VetVelt as a tool for further connection and growth for all of us. Sincerely, thank you. Speaking of conferences and doyens, at the end of 2022, we had our first ever VetVelt live event with the doyens of Small Animal Medicine and Endocrinology, Prof Jill Maddison and Prof David Church. And of course, we had the recording equipment switched on to capture the wisdom that just pours out of these two speakers like blood pours from an ear laceration. It is on the walls and on the floor and just everywhere. This recording was one of my personal highlights because the jaundiced cat case can seem so bloody vague, and Prof Jill made it so bloody simple in the session, while also completely shifting some of my very long-standing beliefs around liver enzymes and liver testing in both dogs and cats. I also loved it because we did this session as a sort of a live podcast style Q&A/case discussion session, which gave us a lot of audience participation and unearthed some real gold way beyond just a list of facts. Now, it is a live recording, so it's not studio quality audio, but I think it is perfectly clear, and where it's not, I've done some magical post-editing or sometimes recorded myself asking some of the questions from the audience where they were a little bit hard to hear to make sure that you can hear what they said. We shared this episode on our subscriber clinical podcasts a while ago, along with a bunch of other stuff from the conference. If you don't know about our clinical series, then check it out at VVN for VetVelt Network or vetveltnerds.supercast.com. So that's vvn.supercast.com, or click the link in the show description wherever you're listening to this. And if you do know about it and you haven't subscribed yet, then, like Lara Bingle said, where the bloody hell are you? Sorry, inside Aussie joke. But seriously, you are missing out. Now we're bringing this recording to all of you with the support of Elanco Australia, who were also sponsors for our conference last year. So those of you who are there can thank Elanco for some of those wonderful meals. And if you're thinking, I know the name, but I can't think what Elanco sells, they're the makers of products like Advocate, Milbumax, Serestro, and Credelio Plus. So basically, the stuff that keeps your patients parasite-free and healthy so that you don't have to deal with too many weird vector-borne diseases. So shout out and thank you to Elanco Australia. Okay, let's get into it with Prof Jill Maddison and Basil, the jaundiced cat.
It's a jaundiced cat called Basil, and he's a 12-year-old neutered domestic shorthair cat. He's got a 3-week history of anorexia, hasn't wanted to eat. He intermittently vomits bile-stained material. He's quite depressed. On physical exam, he's thin. He's got a dull, ill-kempt coat. He's depressed and lethargic. He's got jaundiced sclera and mucous membranes. He's about 5% dehydrated. He's got a heart rate of 160. And he's pyrexic, he's got a temperature of 39.7. So, and a normal thoracic auscultation. So that's the cat that presents to you. He's not insured, but they're okay to invest in him, but they want to know what their money is going to get them.
That gets philosophical, but when you were talking this morning about thinking, and you talked about fishing, instead of targeted going after something.
Yep.
Because what we do more and more is we fish with dynamite, don't we?
Yeah.
We just go, this is everything. And he's going to get it. Bloods, full bloods, blood gas, blood smear, send the bloods off, get an ultrasound.
Yeah, and what are you going to say? So I'm the owner, and I say, well, that's great, but you're now about to charge me. And I'm going, so is it possible that he's got anything treatable? What's the prognosis for the options that he has? You know, should I just kill him now? Like literally, is every possible option a nasty option, in which case let's have a conversation about that? Or is it possible that he's got something that we can think about? Now with him, if you want to pattern recognise him, that's absolutely fine, but you've got to know your differentials. So there aren't that many things that will cause jaundice in an elderly cat, but you have to know your differentials, you have to know what the prognosis is for those, and you have to know how to diagnose them.
So should we define, well, what do we think if we're going to define this problem? Let's start with that.
Well, he's easy because he's jaundiced.
So the jaundice to me is lovely because it goes, well, we immediately narrow it down to pre-deliver, the liver, post-deliver.
Exactly. So you say, do I have pre-hepatic disease? Could he be jaundiced because he's got hemolytic anemia? Do I have hepatic disease? Do I have post-hepatic disease? Okay. So what is your problem list?
Oh, it would be, your jaundice would be the most localising problem.
Yeah, right? But what else is on your problem list?
Oh, we go, 3-week history of...
Pyrexia.
Okay, yeah. I was going through the...
Sorry, wait, but I just... In order of importance, come on.
Yeah, in order of importance. We got dull, lethargy,
yeah, exactly.
3-week history of inappetence or reduced appetite, weight loss, dehydration, vomiting. A lot of it's really not necessarily localising, it's just ill.
Yep, so they're what we would call non-specific problems. But one of those problems we need to definitely make a note of, because I think we'd probably all agree, if we explain why he's jaundiced, we'll know why he's vomiting. The pyrexia is probably something we need to keep there because it might or might not limit our differentials. So we need to create our problem list with all the problems on it to make sure that we don't miss something that is, because we've got so focused on the jaundice. The other question we've got to ask is, do you think on the balance of probabilities that all of the problems on that problem list are due to one disorder? Do you think on the balance of probabilities with this cat...
Very possible.
Yeah, exactly. Yeah. Very possible. If he came in with, cats, as they say, go shopping for all diseases, he might have some changes on his... if he was PUPD, we might say, has he got other diseases going on as well? But that's one decision that we make is, I think on the balance of probabilities, it's likely one disorder, which means if I solve the vomiting, I'll solve the rest of them. And the pyrexia becomes a problem that is there as some background information that's probably going to help me when I'm thinking about differentials. And now...
So testing.
No.
Oh, come on, can I just...
No.
I've invented Dexiclan fluids.
You can give him fluids. He's got fluids, okay? He's got his fluids. So, you want to test.
Yeah.
But why?
Well,
why do you want to spend my money?
Okay, what I would love to do, very simple, straight, and I'm going to put myself on the line.
Yep, go for it.
Wrong. I'd love to just do a PCV-TP and a blood smear.
And why is that?
Because I need to see whether he's hemolyzing. Is he yellow because his liver's in trouble?
Exactly.
Or is he breaking?
Exactly. So our first question was, does he have pre-hepatic, hepatic or post-hepatic disease? And the easy one to separate out from the pack is the pre-hepatic. So you absolutely want to do a PCV. That's great.
So
I'm off the hook. Who's next?
What level of PCV would you expect him to be if it was pre-hepatic? It'd be a pretty significant...
It should be, yeah. I mean, he might have a mild PCV decrease if he's got anemia of inflammatory disease or something, but for him to be jaundiced like that, you'd expect it to be a significant... It may or may not be regenerative, it depends on... And also depends, of course, on the cause of it. It doesn't have to be immune-mediated, it could be parasitic, blah, 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 blah.
Yeah.
But that's the first key question. Because once you do that, and let's say he comes back with a PCV that's pretty normal, which we'll see in a moment, then your question is, does he have hepatic or post-hepatic disease? And that's where you say, okay, what are you going to do to try and sort that out?
One step backwards. Let's say he's 5% dehydrated, right? Could you theoretically then have like a slightly elevated PCV, which then maybe it was 12 or 13 PCV, but now it's 18 or something like that?
Well, it depends on, do the math. So if he's 5% dehydrated, how much is his PCV going to go up?
I've never thought of it that way.
Yeah, no, not much. Only like 2
So
or
it's
3.
not much.
Yeah.
It's not much.
Yeah.
So if you do the math, then that means that if he had a PCV of 18 and he's 5% dehydrated, it's only going to go down about 0.9 of it. It's not going to go down by very much when he's rehydrated. What I'll say to you now is that, okay, so let's just say you've done your PCV, and let's just say you've decided he doesn't have pre-hepatic,
Okay.
right? And now you want to do some tests, but now you've got to think about your differentials. Now you've got to, I want to know as a client, what are the options? Now you can pattern recognise here, it doesn't matter, because now we're just talking about hepatic, post-hepatic disease. So what are the options for this cat? Because that's what's going to drive what you're going to spend your money on.
Jill, I know you just talked about differentiating between hepatic and post-hepatic, and I know we used to set a lot of store by conjugated and unconjugated bilirubin, but we don't do that anymore, is that correct?
No, yeah. So it really doesn't help at all. So, and in fact, a lot of labs now won't even measure it. So you might have the occasional animal that's fully conjugated and hardly any unconjugated, which means it's probably post-hepatic. And you might have the really, really unusual case where it's all unconjugated and therefore it's pre-hepatic. But because bilirubin is such a sort of damages the liver, most of them have a mixture and it really isn't enough of a differentiation.
Thanks.
Quick sidetrack before we go. For the case that's not as obviously yellow, where you go, there's a bit of a tinge. Am I right in saying bilirubin should be up if it's yellow? Like
Bilirubin should be up. Yep.
If I think, are you yellow, we run bloods or run bilirubin, and it's normal, we go, okay, you're not yellow?
Yep.
Yeah, cool.
But, so just as a little aside, one of the things so the bilirubin reference range is about 0 to 15. They don't get jaundice until it gets to 45. So you can have an elevated bilirubin and them not be jaundiced, and they can have an elevated bilirubin and not be jaundiced for non-pre-hepatic, hepatic, post-hepatic reasons. So they can have it if they have inflammatory disease, and in cats quite significant. In people, they can have it with fever. We don't really know whether that happens in cats. In horses, of course, the most common cause of jaundice is anorexia. Maybe in cats their bilirubin goes up, but they don't get jaundice. But it's the inflammatory septic cat or dog that can have an increased bilirubin that isn't jaundiced, but it doesn't mean that they've got hepatic disease. And it's the most over-interpreted test, I reckon. I have so many vets tell me, oh, the bilirubin's 16, it has to have a problem with its liver. No, probably it's just got inflammatory disease. The rate-limiting step for bilirubin excretion is the actual excretion from being conjugated and then going into the gallbladder. And the enzymes and transporters that do that are affected by inflammatory mediators, infected possibly by fever, and the anorexia probably changes those mediators as well. So whether it is an intermittent fasting, I would find it hard to believe that just because the gallbladder wasn't contracting, that would increase it. But I absolutely agree. You've got a bilirubin of 25. There can be all sorts of things that it is, and you need to hunt for... It still could be liver. So if my cat's got hepatic disease, what are some of the causes of hepatic disease in the cat that will cause jaundice?
Okay, so at this point, our audio wasn't all that fantastic. So I might interrupt every now and again and tell you what the audience said. So the first answer here was cholangitis.
Well, cholangitis is a pathological term. So what type of cholangitis? You're right, but what type of cholangitis? Because there are different types.
Just inflammatory.
Lymphocytic, plasmacytic, or bacterial.
Yeah, so we can have lymphocytic, plasmacytic, or we can have neutrophilic. So they're two and treated very differently. So what else?
Lymphoma.
Absolutely.
Hepatic lipidosis.
Yeah, absolutely. And especially in a cat that's got a 3-week history of anorexia.
Viral causes.
Well, FIP can. Yeah. He's probably in the wrong age for FIP, but the FIP definitely can.
Triaditis.
Well, triaditis is going to be so he could have cholangitis as well as have pancreatitis as well as have whatever. So there aren't that many, are there? But they're going to be potentially different prognoses. So that's me hepatic. And then what about the post-hepatic? What are some options for post-hepatic?
Bile duct obstruction.
But due to what? So pancreatitis is one.
Cololiths.
Yep, could be often subclinical, but possible, yeah.
Foreign body touch?
It would be you could get a foreign body getting up there. Foreign body sitting right at the outlet of the bile duct, because remember in cats, have a co-pancreatic and bile duct opening. So, and you can have, if you have pathology right at that duodenum, it could cause, definitely could cause it. Yep. Neoplasia of something along the biliary tract or of the pancreas. The pancreas just wants to hang out with the liver. It's just got FOMO really bad, so it just hangs out with the liver, and anything that happens to it will affect the liver. He's not a dog, so he's not going to have a mucocele. They can get sort of bacterial infection in the gallbladder. That's probably it. Or you could get, a rupture, but he's not presenting like a rupture. My point is that you need to know that to be able to say to me, the client, so some of that's very treatable and some of it's not so treatable. Some of it will be easily treatable, some's treatable but it's more expensive and it's longer. Some of it has got a better prognosis and some of it doesn't. But also it might influence what tests you want to do. So the question is, if you do, so blood count, absolutely, right? You need to know what this cat's PCV is because your question is, could he be pre-hepatic? But once that goes, the blood count would be useful because it may give you information that he's got significant inflammatory disease. He might be leukemic, it might be whatever. The question about the biochemistry is really interesting because what your question now is, and this is why we think about them together, is what is it and where is it? Because it's really hard to separate them on bloods. So to separate hepatic from post-hepatic. So that's why we have to think about the pathologies and think about, well, how am I going to find that out? And the problem that we have is that the liver enzymes aren't going to tell us. ALP is very insensitive in the cat and will go up with both hepatic and post-hepatic. ALT will go up with hepatic and post-hepatic. Bilirubin will be up, so what? So the ALP in the cat has got a really short half-life. It's got a half-life of 6 hours compared to 72 hours in the dog, which means that it's quite an insensitive enzyme. Also, they hardly make any of it. And so in the cat, alkaline phosphatase goes up with cholestasis, but it may not. And so you can have lots of cats that will have. You would never get that pattern of enzymes in a dog with a jaundiced dog. If you've got that pattern of enzyme, not the ALT so much, and maybe you'd get it if they're really advancedly cirrhotic, but usually in a jaundiced dog, you would expect the alkaline phosphatase to be up because it's actually a more sensitive marker of cholestasis than bilirubin is. But in the cat, it's got a short half-life. They don't make very much of it. And so in the cat, unlike in the dog, there's very few things that will put up the ALP, which is not primary hepatobiliary disease. So pancreatitis will, but I call that a hepatobiliary disease. Hypothyroidism will, but it's probably the bone ALP, not the liver ALP that goes up in hypothyroidism. And then not much else. Doesn't go up with steroids, doesn't go up with phenobarbital, doesn't go up with all the things that it goes up with in dogs. So what else could we maybe do and see?
I just want to go back a step. So the stuff that we learned about the patterns of ALP to ALT and that helps you differentiate the hepatic lipidosis.
The only pattern that helps with lipidosis is if because in cats the gamma GT should be higher than the ALP, and for some reason in lipidosis it's reversed, so the ALP is higher than the GGT. So that's a reason to do the enzymes, but you must include a GGT.
Does that pattern with the elevated ALP versus ALT or elevated ALT, does that work in dogs?
In dogs?
Yeah, an ALP is more likely to be raised than a gallbladder obstruction,
Not always.
Okay.
You might see amylase. I know it creates me so old-fashioned, but you might see amylase and lipase.
No, not in a cat. So amylase is absolutely useless in a cat. They hardly produce any of it. So amylase and lipase that we have in our normal biochemistry profile doesn't help us at all. So we might want to do feline pancreatic lipase. So what I'm going to do is, so we want to do feline pancreatic lipase, we want to do some enzymes, we might want to do some imaging because we've said that might help us. All of that's absolutely fine. So why don't I show you what the results are and then see what questions that brings up. So we did that. Path results, his PCV was 25. It's a bit dehydrated, it'll go down to about 24, but really not enough to say that he's got hemolytic anemia. So he's mild anemia once rehydrated and fairly happy he doesn't have pre-hepatic. He had a moderate inflammatory but not a septic leukogram. He had increased ALT, it was 300, reference range up to 60. He had bilirubinemia, no surprise there. He had a normal ALP. He had a normal feline pancreatic lipase. He had a normal amylase. Bile acids weren't requested. And on imaging, he had no ultrasonographic abnormalities.
So, sorry, you said bile acid wasn't
asked for.
So we don't know.
We don't know what his bile acids are. Because why would we want to do bile acids? They won't tell us anything that we don't already know.
Jill, can I go back to the bile acids, please? You said that there was no point doing them because the cat bilirubin was increased.
Yeah.
And that's because you'll get a false result. Because
no, it's not false. They're increased.
Oh, yeah. Okay.
Yeah,
So, but the reason why we do bile acids isn't because of liver function.
So this is a bone of contention. So bile acids absolutely are produced in the liver, and in one way a measure of hepatic function, except that I have huge fights with people about this. So they're produced in the liver. If they were a true measure of hepatic function, then it should be like albumin. They should go down with hepatic disease, hepatic failure, but they don't. They go up. And the reason why they go up in hepatic disease is because the ability of the liver to extract the bile acid becomes decreased. But they can also go up when we've got a shunt, and they're going up because of the shunt, not because the liver's failing. And they also go up when they can't be excreted properly. So there's three ways bile acids go up. They go up if they're coming from the gut, and then they go bypass the liver, and they don't go through the liver. So that's a shunt, got nothing to do with function. They can go up if the liver is dysfunctional, and that's got to do with extraction problems, not with synthesis problems. So unlike albumin and unlike coagulation factors, which are synthesised in the liver and go down when the liver is in advanced failure, they go up because the extraction doesn't happen, or they go up because you've got cholestasis within the liver or outside of the liver, so slowing down of the bile. Now, once you've got bilirubin increase, you know that you've got cholestasis. So the bile acids don't tell you anything more than you already know. There is no relationship between the level of bile acids and the prognosis or reversibility of the lesion. The only time you would want to do bile acids in a jaundiced cat or dog would be if you were concerned they had hemolytic anemia, and that was why they were jaundiced, because they may give you some idea about the liver, or in a septic patient that's jaundiced because it's septic, which is incredibly uncommon. But most of the time, 99% of the time, in a jaundiced animal, they're not going to tell you anything that you don't already know. They're not going to quantify the degree of problem. They're not going to tell you what the reversibility is. They're not going to tell you what the prognosis is.
I get that, but I'm still confused because this cat could still have extraction problems, still could have issues there.
In the liver?
Yes.
Yeah, but I know that.
Yeah.
But I already know that. I know that because the bilirubin's increased. I've got a jaundiced cat. It has to have hepatic or post-hepatic disease. So I think the two reasons I do bile acids would be, one, hunting a shunt, absolutely, for sure. And then if I was hunting liver disease and wasn't yet convinced that the enzymes were telling me enough that it had liver disease. So the clinical signs fit, the enzymes are then they're 5 times elevated, something like that, and I'm going, is that secondary or is it primary? Then bile acids for sure. I can show you some data that we did in some cats and dogs, because one of the messages about bile acids is that not so much in the cat, you don't seem to get false positives in the cat, or we didn't. You can get false positives in the dog easily, so other things put it up, like conjugation of bile acids in the intestine by bacteria. And so the reference range for bile acids, they talk about 0 to 25, and if it's above 25, you've got a problem. Well, really in a dog, it's probably up to about 40 or 50 before you can be sure it's definitely liver. In the cat, they don't tend to get false positive, but what was really interesting in both the dog and the cat, we've got a bunch, and the numbers are there, I can't quite remember all of them, but something like 15% of our cats and dogs who had card-carrying liver disease, card-carrying biopsy-proven, shunt-proven, whatever liver disease, who had normal bile acids. So one of the messages about bile acids is they can't rule out liver disease, which is really important, in particular in cats, because cats just, the enzymes are weird, the ALT's got a shorter half-life as well, it doesn't go up as high, they just don't like to tell the blood there's something wrong.
So unless we do like a biopsy or something, then would we just try treating?
Yeah, you can. You can definitely try treating.
So say you're looking at bacterial or lymphocytic, plasmacytic, you do your 48 hours or whatever antibiotics and just supportive fluids and things.
Yeah, you could do that. 48 hours probably isn't enough, but yep.
And then if we're not getting any improvement at a certain time, then...
Yep, and you give him steroids? Yep. And if you give him steroids, so let's say you give him antibiotics and nothing much, he'll probably look a bit better just because he's got some antibiotics on board. He might have a bit of encephalopathy going on. The antibiotics will sort of affect his gut. But let's just say he doesn't respond to antibiotics. So you load him with steroids, absolutely fine. And he does really well. He starts looking really well. What does that tell you? Does it confirm your diagnosis or... Because what are the two options if he's really improving on steroids? So he's either got non-suppurative cholangitis or he's got lymphoma. And they've got very different prognoses. So the point, though, is that that's the conversation you have to have with the owner to manage their expectations. So you need to be clear about what the options are, not just, oh, he got a bit better on steroids, and be clear to say, this is, you know, it may be that this is great news. It may be that he is going to respond incredibly well to steroids, and it may be because he's got lymphocytic cholangitis, and that's going to be great. Or it might be that this is the start of responding well to lymphoma and then he's going to crash and burn, or he might not. And then the question is, well, maybe should I throw some chlorambucil in there? You know, who knows? So absolutely not saying you have to biopsy this cat. What I'm saying is you need to be aware of what the options are and what the potential prognosis is in response so that you've got a clear discussion with your owner.
You said that we were still trying to work out whether it was hepatic or post-hepatic, but that our ultrasound imaging was normal. What sort of causes for post-hepatic would you still see normal imaging results?
So post-hepatic, ultrasound's great for post-hepatic really, because most of the time you will see what's there. So a study that my student did this year, looking at correlating the biopsy results in cats with their ultrasound results for parenchymal disease. Because the post-hepatic, you know, if there's stones there, or there's cholecystitis, or there's a mucocele, or there's, you know, pancreatitis, but not even pancreatitis necessarily. But the parenchymal disease is an issue. And so one of the questions that I've got here is, was the ultrasonographer blind? So in the analysis that we did, and these are all cats that had been ultrasounded at the RVC, so specialist ultrasonographers, you know, all the kit, blah, 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 blah. And what we found was that there were two ways that it was analysed, but one was, did the ultrasonographer call that there was pathology there, or did they say no? And was there pathology there based on biopsy or cytology? And then if they did call it, did they call it right? You know, so if they gave a range of possibilities, how right were they? So what it turned out was that they were wrong a lot of the time what they called. Even if they gave a range of options, it would be something else. But the main take-home message was that there were all sorts of different types of liver disease, but we analysed the inflammatory and the neoplastic. And what it turned out was that if they had neoplastic liver disease, then I think one of the cats didn't have ultrasonographic changes. But if they had inflammatory disease, if they had cholangitis, then something like 40% of them didn't have ultrasonographic changes. And so the take-home message again is ultrasonography can never rule out liver disease, parenchymal disease, and particularly so if it's inflammatory, at least in cats. But of course, cats are more likely, other than pancreatitis, and then in another study that we did, the general gist would be that about 20% of cats that have pancreatitis will not have an abnormal pancreas, and that's with specialist ultrasonography.
Jill, in terms of like thought process, I'm just trying to see what I was thinking before you gave us the results. Neutrophilic cholangitis is more common in terms of signalment in a younger cat as opposed to like an elderly cat. And also the history, like it's a 3-week history, whereas neutrophilic cholangitis should be more acute. So nothing is absolute in medicine, so can't exclude it, but in terms of probability, it would be less likely because of these things.
Yeah, so the lymphocytic cholangitis tends to be younger. There's some suggestion it's more common in males, and they, weirdly, will often present with weight loss despite a normal or an increased appetite. So they tend to, they're kind of weird that way. So, and they also aren't nearly as frequently pyrexic. And remember, this cat was pyrexic. So the fact that you've got a jaundiced pyrexic old cat, you'll probably, neutrophilic cholangitis or lymphoma are sitting up there saying hello. If he was much older, then you'd bring in FIP because it has a bimodal thing. Or if he was young, then it might be FIP as well.
Jill, sorry, I might have missed this before, but were the other liver functional parameters normal, like albumin, glucose, cholesterol?
His albumin was fine.
Everything else
I can't remember what his cholesterol is. Cholesterol can go up or down with liver disease. I'm not sure what it tells you, really.
Okay.
Yeah, but good question. But looking at the albumin, because if his albumin had been decreased, then that would absolutely plant it firmly in the liver. And that's a absolutely really good point. Whereas if he had post-hepatic disease, you would not expect his albumin to change.
So really, if the owners were committed and we've got to that point after the ultrasound, really it's just biopsy and then that's the other way, right?
And this is a real case, I promise, and a real case in general practice. So the owners were committed and he had biopsy confirmed neutrophilic suppurative cholangitis and pancreatitis. They didn't biopsy his gut. And then these are the key questions that I think come from this cat. So why were the liver and pancreas so shy about telling the blood there's something wrong? The liver enzymes are really short-lived. They don't like to tell the blood there's something wrong. Would it have been helpful to do bile acids? And the answer is no, it wouldn't have told us anything. And then in particular, so we've talked about amylase. So amylase, really short life, not much of it, no use. ALP, if it's up, take notice of it. But if it's not up, whatever. Bile acids, not a point here. PLI, we haven't talked about yet. And then was the ultrasonographer blind, which is... So I guess the thing we haven't talked about is PLI. So my $2 worth. Okay, and this is based on a study that we did a couple of years ago on 275 cats with pancreatitis. So it's the largest study on cats with pancreatitis looking at PLI. Now, the problem with pancreatitis in cats is that being sure that the cat's got pancreatitis is difficult because unlike dogs that do their card carrying, vomiting, abdominal pain, blah, 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 they don't do it. So in an ideal world, the sort of gold standard is biopsy, although even that can be challenging. And as we know, we're not going to run around biopsying the pancreas in every cat that we think might have pancreatitis. So we used as a criteria that the cats had to have confirmed pancreatitis. They had to have clinical signs that were consistent. Well, that's easy because they can have practically anything. They had to have nothing else that could have explained those clinical signs. They needed to have ultrasonographic changes that were consistent with pancreatitis, what our ultrasonographers said, and for some of them they had biopsy or cytology. So of the 275 cats, with SPEC, this is one you send off to the lab, so the reference range is less than 3.5, values greater than 5.3 is said to be consistent, and there are values in the grey zone. So what we found was, and there are studies that will say that the sensitivity, so in other words, how good is the test at picking up cats with pancreatitis? So in the literature, it's reported to be about 67%, which means that about a third of cats with pancreatitis will not have an elevated PLI. Now, that study was a really good study in that every cat was a study of 28 cats. Every cat had a biopsy, a card-carrying biopsy, but it was only small, it was 28. In our study of 275, where we diagnosed the pancreatitis based on clinical signs, ultrasonographic findings, and for some of them on biopsy, and no other disease that could have explained their clinical signs, what we found was that we had 24% false negatives. So we had a quarter of our cats who had what seemed to be pancreatitis, but every other criteria that you could name did not have an increased PLI. And in fact, because we excluded cats with ultrasound changes, and other studies suggest that about 20% of cats at least with pancreatitis have normal ultrasound, we may have, in fact, a higher number of false negatives. But the other thing is specificity. So this is where you say, if the test is positive, is it a true positive? And so if it's increased, does that mean, yep, this cat's definitely got pancreatitis? And what was found in the literature, when the test first came out, it was sort of touted as being close to 100%. And then more studies came out, but again, lots of not very great studies, not very well controlled, and it's a problem disease. So there was a sort of suggestion they're up to a third false positives. We actually found that the false positive rate was relatively low. It was about 10%, and the higher the value went, and I think when it got to about, so it was above 5.3, I think when it got to about 12, the tests would show that, you know, the specificity was now like about 99%. So the message in cats is completely different than the PLI in dogs, which is another story, which is that if the PLI is positive, so the SPEC that gets sent off, then you've got a pretty good chance this cat has pancreatitis. I mean, there will be some false positives, but it's not very high. But if it's negative, it doesn't rule out the diagnosis. The SNAP test, it's got a higher sensitivity. There's not really good numbers around about it, but it's a higher sensitivity, so you probably have a slightly lower false negatives, but it's got a lower specificity. So you'll have more false positives. How we manage pancreatitis in cats tends to be in flux. You know, we had this little period where Carolyn Mansfield was saying, for example, we think it's bacterial, I think you should treat them with antibiotics. And I've certainly treated a couple with antibiotics and they did really well. And then now they've gone back saying, oh, no, we don't think so. Kenny Simpson saw bacteria in there, said maybe it's bacterial. So in the cat, because it's grumbling and ongoing, I will tend to do it if the owner can afford it. But if I had to... And the problem, it's a sort of combination. So the money spent on an ultrasound, I can't rule it out on the ultrasound and I can't rule it out on the test, but probably the combination of both of them is most likely to give me the diagnosis. Yeah. You don't do them in dogs. So in dogs, it's the complete reverse in that in dogs, when you've got a dog that presents with acute abdomen, you're not going to wait around for a PLI. You might do the DP, DDG, whatever, but the same thing applies. And in dogs, roughly, it goes roughly that you've got a 20% false negative rate and a 20% false positive rate, roughly. And in dogs, if you want to spend your money, what is much more important is that you make sure that that dog does not have an acute abdomen for something else, because that's when it's surgical. So that's when you need the surgeons. And that's when it's important. And so the imaging, radiology and ultrasound, not just ultrasound, because, you know, intestinal obstruction, that's when you want to spend your money on the imaging. So I can't think of the last time I did a PLI in a dog, but I have done them in cats.
So when you see that yellow cat, it's great. You're going to do the very basics. So PCV-TB.
Yep.
That's going to tell you a lot. And then I feel like almost the next most valuable thing is going to be imaging to rule out post-hepatic, so make sure there's not a neoplasia or something like that.
Yep.
Your biochem doesn't tell, and it's FPL, if the biochem.
I guess the only time the biochem will really be helpful, one is the albumin. So if you've got a low albumin, then this cat's really got a really sick liver. And two, in the cats that have hepatic lipidosis, which is uncommon for sure. In our study, we had, 10% of them had a diagnosis of hepatic lipidosis. Don't get Professor Church started. I can just feel his eyes boring on me, and I'm just going to leave that for him. But in cats with hepatic lipidosis, it has been established that, and this is what we would call, people refer to as primary hepatic lipidosis. In other words, they don't have underlying disease other than what triggered their anorexia in the first place. And those ones are the ones that have the higher ALP phos than the GGT. So that might be something. But then hepatic lipidosis is also kind of easy to diagnose on an aspirate rather than needing a biopsy. But yeah, imaging, absolutely. Yeah.
I mean, beyond that, you're going to go for biopsies.
Yeah,
basically.
Biopsies.
So if you're not anemic and there's nothing weird on a scan, we're going to do bloods to be sure there's nothing else. But
and the reality is that probably, if you've got a jaundiced cat, it's not anemic, you do a scan and it's a good scan and you know what you're doing, and there's nothing on the scan, then the chances are it's got inflammatory disease. But what you don't know is whether it's neutrophilic or lymphocytic. But as we said, in this cat, because of its age, because it's pyrexic, it's much more likely to be neutrophilic than lymphocytic. But if it was younger, and particularly if it presented, so a lymphocytic cat often presents with, they can be polyphagic, I don't know why, but they often present with polyphagia, being jaundiced and weight loss, and so they kind of present differently.
Does albumin give you any more information other than it points to liver? Does it tell you about severity?
Yeah, so the albumin, obviously the albumin can go up if they're dehydrated, and it can go down if they're losing it in the gut or they're losing it in the kidney. But if you're happy they're not losing it in the gut or the kidney, then if you have an animal with liver disease that is hypoalbuminemic, they have lost 80% of their liver function. So they are the ones that are also going to have clotting factor issues as well, both clotting factor synthesis and clotting factor activation. So they're sick. Interestingly, another study one of my students did this year was looking at the differences in ClinPath parameters between dogs with shunts, porticable shunts, and cats with porticable shunts. And cats were much less likely to be hypoalbuminemic, which I find fascinating. I have no idea why, but much less likely. Professor Church.
Do you want to just comment about the hepatic lipidosis?
Oh, for heaven's sake, no. I don't. I really don't. David doesn't believe in hepatic lipidosis. Everybody else in the world at least believes that there is a syndrome that cats will get if they have been overweight, don't eat for some reason, and their liver becomes stuffed with fat, and the only way they get better is to feed them. He doesn't believe it exists.
I'd like to put a
look,
case
there's a
for the
Christmas
defence
tree.
here for a second. I didn't say I don't believe it exists. What I said was I don't think a cat with a swollen liver because of lipid deposits is going to be inappetent because of the swollen liver and the lipid deposits. That's what I'm saying. So what the point is, they get fatty liver, but that isn't the reason they're not eating.
No,
Something else is.
it gets triggered by something else.
So why do we call it hepatic lipidosis and describe it as some bloody syndrome when it doesn't make any sense?
Isn't it time you talked about Addison's disease or something?
If you like that format and you like the way we ran that session, then you will probably like what we're going to do later this year at the Vets on Tour Wanaka, that's a New Zealand conference that we will be doing some more live podcasting on. So if you haven't come across it yet, Dr. Dave Collins, who is a regular guest on the Clinical Podcast, hosts these amazingly fun conferences around the world that is focused a lot around skiing and also some continuing education. No, I lie. Really good continuing education, but always in a fantastic location. And this year, from 14th to 18th August, that's 2023, we are going to the Edgewater Resort in Wanaka. And I will be going again as the Vet Vault to do some live podcasting with incredible guests talking about palliative and hospice care. And I spoke to one of the people who are going to be presenting there that palliative care doesn't have any relevance to me as an emergency vet. And she said, no, what we do in emergency vet, those end-of-life conversations, that's all hospice care. So I'm suddenly very interested in these sessions. We're talking about oncology, and then we are talking about management and leadership. So great sessions. Join us for the CPD. Join us for heaps and heaps of skiing. Join us for the legendary, some might say notorious party night that always happens on Vets on Tour. That's 14th to 18th of August 2023. It's not even on the website yet, so if you do want to get in early, contact Dave at vetsontour@gmail.com or look for Vets on Tour on Facebook. I'll also put some links in the show description. Love to see you there.